Morning or good evening to all of you. Thank you for your presence at the third OncoDNA webinar of the year. This webinar will today cover the advancing utility of genomic testing in routine oncology practice. During this webinar, you will have the chance to raise your question through the question section at the right part of your screen. The speaker will take the time to answer them live at the end of the webinar. So just to start, may I ask you to answer this short question that will appear on your screen in a few seconds. Okay, no, still a few to vote. Okay, thank you for this. So we have the pleasure to welcome today two experienced speakers and scientists, Dr. Cheng Boon and Dr. Philip Beer. Dr. Cheng Boon is consultant clinical oncologist at Clatterbridge Cancer Centre in UK. And Dr. Boon will explain why he believes it is our responsibility to help to translate the molecular advances into clinically relevant applications. Dr. Philip Beer is physician, scientist, and precision oncology specialist in UK. He operates across the commercial, academic, and healthcare sectors. Its current projects include clinical implementation of cancer genomics, biomarker discovery, and early phase clinical trials. Modern molecular technologies yield large amounts of genomic data from tumor and plasma DNA. Questions remain, however, as how this information can be used in routine clinical practice. Dr. Beer will look at current application and the emerging utility for cancer genomic analysis. I give now the words to Dr. Philip Beer. Thank you, Philip.
So I'm going to be talking about the advancing utility of genomic testing in routine oncology practice, with a focus on what kind of testing is useful today, right here and now, looking at tumor mutational burden and microsatellite instability in the context of immunotherapy, and also the Ntrack fusions, which have been the scope of a recent approval by the FDA and are generating a lot of interest in the field. I'm then going to move on and talk about genomics that are just around the corner, so things that are beginning to come into clinical practice or where there is very promising clinical trial data, with a focus on circulating tumor DNA assays, and then two emerging targets, the PI3 kinase and homologous recombination deficiency. So with respect to immunotherapy, these drugs have been very successful, but only for a minority of patients with cancer. So there is a pressing need to identify better predictors of response. And if we understand the basic physiology involved in the T cells killing the tumor cells, then we can understand what kind of genomic events will predict response or resistance to these agents. So the T cells need to be able to recognize the tumor cell by binding the T cell receptor to an antigen expressed in the HLA complex in the surface of the T cell, of the tumor cell, sorry. And the T cell then has to kill the tumor cell, usually by engagement of the interferon signaling pathway, resulting in cell death. So one of the early markers of response that has come to the fore is the tumor mutational burden, the number of somatic mutations in the tumor cell. And this is likely a reflection of the repertoire of antigens presented on the tumor cell, and therefore the likelihood that a T cell will be able to recognize the tumor cell and kill it. So the more somatic mutations in the tumor, the higher the likelihood that there will be T cells that are able to kill those tumor cells. And this is work published a few years ago now, demonstrating very nicely the range of tumor mutation burden across different cancer types. So we know that childhood tumors tend to be quiet. There aren't that many mutations. At the opposite end of the spectrum, you have tumors that have been driven, that are caused by strong carcinogens. So sunlight in the case of melanoma, and cigarette smoke in the case of lung cancers. And these produce tumors with very high mutational burdens due to the extrinsic oncogenic effects of these carcinogens. Another interesting subset of cancers with high mutational burden are those who have intrinsic microsatellite instability. And the red circles there show the uterine and colorectal cancer with these outlying mutation burdens, and these are due to microsatellite instability. And in this intrinsic error of DNA replication that these tumors acquire, you have a particular type of tumor mutation burden. And the reason is that with this error, you get slippage in copying of long polymeric tracks. So where you have tracks of repeats, either of the same DNA base or of small motifs of 2 or 3 DNA bases. And when you get this slippage, it can produce an abnormality that is out of frame. It changes the reading frame. And this means that when the protein is produced, it has different amino acids in it. So the consequences are that microsatellite instability produces proteins that are more abnormal and therefore more visible to the immune system when compared, say, to missense mutations. So microsatellite instability produces a double hit of a high mutation burden and a high proportion of abnormal proteins that makes these tumors particularly prone to being destroyed by the immune system, and therefore particularly good candidates for treatment with immunotherapy. So this graph shows data from a recent large publication that looked for microsatellite instability across a wide range of solid tumors, and also investigated whether the microsatellite instability was due to an inherited mutation as part of the Lynch syndrome, or whether it had just acquired in the tumor itself. So you can see in this large cohort, this picks out the well-recognized tumor types, colorectal and endometrial. You also see a high prevalence in some rare cancer types, small bowel and adrenocorticoid tumors. But if you have big enough numbers, you can pick up a few % of microsatellite unstable tumors all across the common tumor types, including tumors we don't usually associate with this abnormality, like pancreatic and prostate. And these are rare findings, but one of the recurrent themes of precision oncology, and one of the big needs to be testing all our patients, is that a lot of the abnormalities that we find are rare. But as you begin to find lots of rare abnormalities, then the proportion of patients where you can use targeted therapy becomes significant. So precision oncology has turned cancer into a large number of rare disorders, and this is a good example of this. If we actually take a step back and look at different causes of tumor mutation burden across some of the common tumor types, this puts together the high mutation burden, which is predominantly due to exogenous carcinogens, shown here melanoma, lung cancer, and also esophageal cancer, which is related to cigarette smoking and alcohol. And then also adds in these intrinsic defects of DNA repair, microsatellite instability, and also polymerase deficiency. This is most common in colorectal cancer and can occasionally be seen in endometrial cancer. This is an inherent defect in DNA repair that causes very high tumor mutation burdens, but these are predominantly missense mutations. So they're not thought to be as interesting to the immune system as the frameshift and abnormal mutations produced as part of microsatellite instability. And studies are underway to look at how well these polymerase deficient tumors respond to immunotherapy. So across the board, we know that tumor mutation burden is an important predictor of response, and this gives an overview of the proportions of patients that are likely to fit into this biomarker positive category. And the next slide shows very nicely this strong correlation between tumor mutation burden shown on the horizontal axis and the aggregated response rates from clinical trials shown on the vertical axis. So a lot of the original data that I've shown you comes from whole genome sequencing or whole exome sequencing, and these remain the state of the art for determining tumor mutation burden. But there has been a lot of interest recently in working out to what extent that smaller targeted cancer assays can accurately estimate the tumor mutation burden, because we know at the moment that whole genome and whole exome sequencing are not applicable for routine clinical practice. And there are several groups asking this question at the moment, the extent to which smaller panels that are used clinically are able to predict accurately tumor mutation burden. And these are three of the big groups that are looking at this. The most advanced is the American-based group, the Friends of Cancer Research. And certainly the initial data that has been published and presented and that is beginning to come through says that accurate tumor mutation burden predictions are possible with medium-sized cancer panels. So by medium-sized, I mean panels that are reporting 200, 300, 400 genes. So around the OncoDeep panel size. So I think these projects will produce interesting guidelines and help us to understand how we can use these medium-sized panels to best predict tumor mutation burden and therefore immunotherapy response. But the principle is fairly well established now that this is possible. There will be a little bit of fine-tuning as we go forward. So moving on to Ntrack fusions, these have recently created a great deal of interest following an approval by the FDA of a specific Ntrack inhibitor at the end of last year. These are caused by translocations which fuse the Ntrack gene to a variety of partners and produce a novel protein, a novel gene that's translated into a novel protein. The Ntrack family are transmembrane receptor signaling molecules, and the fusion proteins produce a molecule that is constitutively active. It's stuck in the on position all the time, even in the absence of its ligand, and these fusions are strong drivers of cancer. It's always important when a new gene comes along to know how to say it properly, and these kind of gene names are quite common that don't have any syllables in. And interestingly, one of the early trials, or the earlier sets of trials, these Ntrack trials, I think initially many people, myself included, assumes that the trial was alluding to these guys and that actually it was a Star Trek trial. So maybe the gene should be pronounced Ntrack. Although subsequently to these trials, the field seems to have agreed that they're actually pronounced track to rhyme with railway track. So despite the niceness of these Star Trek or Star Trek trials, we pretty much settled on these being the Ntrack family of genes. Now, these fusions are rare in common tumor types. They have been reported at around the 1 to 2% mark in many different solid tumor types, but overall they're pretty rare. Although notably they are enriched in particular subsets of tumors. So shown here, some enrichment in papillary thyroid cancer, strong enrichment in infantile sarcoma. There's also strong enrichment seen in some rare subtypes of breast cancer, for example. But importantly, these fusions do turn up occasionally in all different tumor types. And the striking thing about the clinical studies of the targeted therapy, the targeted Ntrack inhibitor, is that there was a strong efficacy signal regardless of cancer type. So whatever tumor type you have, if you have an Ntrack fusion, then you have a good chance of responding to therapy. And this slide also shows the diversity of tumor types in which these fusions were detected. The other interesting thing about these fusions is that the Ntrack inhibitors work regardless of the family member. So they're also as effective for Ntrack 1, Ntrack 2, or Ntrack 3 fusions. So tying these two pieces of the first part of the talk together, 2018 was an interesting year for precision oncology. We had our first tissue agnostic approval, and that was of the Ntrack inhibitor, approved for use for tumours with an Ntrack fusion regardless of the tumour type. We also had our first approval based on a genomic signature rather than a specific molecular event. So the approval of pembrolizumab for any tumours, again cancer type agnostic, any tumours based on the genomic signature of microsatellite instability. So in the second part of the talk, I'm going to talk about where we are heading in the fairly near future, looking at the role of ctDNA in diagnostics and managing therapies, and looking at two interesting emerging markers, PIK3CA or PI3 kinase family and homologous recombination deficiency. So ctDNA analysis has created a lot of interest with a number of providers offering solutions, a number of publications, but as yet perhaps a little confusion as to where the role of these agents is in clinical practice. And I've tried to capture a couple of the key questions here. First of all, around interpretation of results. What do we do when we get a positive result? And perhaps more importantly, what do we do when we get a negative result? And then if we can understand how we can interpret the results of these tests, when is the best place to be using ctDNA analysis? So the critical issue with the use of ctDNA analyses remains their predictive value. And the important discriminator here is the difference between sensitivity, technical sensitivity, and diagnostic sensitivity. And technical sensitivity asks the question, if there are DNA molecules in the blood tube, am I able to detect them using my assay? And ctDNA assays are now very sensitive, and they are able to detect DNA if it is present in the tube. But a more important issue is that of diagnostic sensitivity, which says, is there actually an abnormal DNA molecule in the small amount of blood that I've taken from the patient? And the early studies of ctDNA tended to be focused on patients with very advanced disease, very high tumor mutation burden, whereas when we've moved them into routine clinical practice, we're now using them to test patients at an earlier stage of the disease, where the volume of the disease is not necessarily so high. And then diagnostic sensitivity becomes extremely important. So in this slide, I've summarized 4 recent studies where analysis is being performed on paired tumor and ctDNA samples. So we're able to know what's going on at the same time point in the tumor and in the circulation. And although these were clinical trial cohorts, they were more representative of the kind of patients that we will see in routine oncology practice. And the interesting thing of these 4 studies is that they give a fairly coherent message. So the messages are that there are a small number of mutations, perhaps 5% or so, that are only found in the circulation and are not present in the tumor. And these are real results. These likely represent heterogeneity within the tumor, subclonal mutations that are perhaps only found in a metastasis and not the primary tumor, or only a subset of tumor cells. We also see a reasonable chunk of mutations in the purple that are detected both in the tumor and in the circulating DNA. But all of these studies have shown a large chunk of mutations, a large proportion that are only present in the tumor, at around the 40% mark. And this highlights the diagnostic sensitivity of these assays. And the most likely explanation for this is that the volume of disease is such that the DNA, the abnormal DNA, has not found its way into the small amount of blood taken from the patient and has therefore not triggered a positive result. So there is still a sensitivity issue with circulating DNA analysis that is not really any longer a technical issue, but is just the ability to actually collect enough DNA to produce a positive result. The kind of things that should flag us for sensitivity are low volume disease, as I've mentioned, also localized disease. So even where there is relatively bulky disease, if it's only in one place rather than disseminated, these patients have lower levels of circulating DNA. Where there is perhaps a residual technical issue is in the detection of indel variants, and these are still inherently harder to detect and to report than simple substitutions. So where is the utility for ctDNA analysis today? Well, probably the best use is where patients are not fit to have a tissue biopsy. And a common situation that we come across is somebody where there is a very high suspicion of lung cancer from radiological appearances, but the patient is unable to go for a biopsy because they're not fit enough, and is often unable to undergo chemotherapy treatment for the same reason. But the physician feels that they may well get on with a targeted therapy against EGFR or one of the fusions. And in this situation, obtaining a plasma sample can be helpful. Another increasing area is where patients have progressed on targeted therapy. And again, lung cancer is a good example here, a patient who has an EGFR mutation receiving targeted therapy, monitoring for emergence of specific resistance mutations such as the T790M mutation can be used to guide the next step in therapy. Similarly, patients with BRCA mutations who have received platinum, the presence of BRCA reversion mutations is a strong indicator that they won't respond to subsequent PARP inhibitor therapy. So overall, the situation with ctDNA analysis is that the positive predictive value is very high. So if we find an abnormality, there is good evidence that this is a good mandate for treatment. So further testing is not required. The presence of an EGFR mutation, for example, in ctDNA is a good mandate to give an EGFR inhibitor. But at the moment, a negative result, the lack of a positive finding, given the sensitivity, the diagnostic sensitivity issues with ctDNA, current guidance would be then to default to a tissue biopsy wherever appropriate and wherever that can be achieved. In terms of moving forward with ctDNA, a potentially exciting application of this approach is in the detection of minimal residual disease. And this is a summary of studies that have looked at patients that have localized cancer that has been resected, and then they have been monitored with ctDNA and look at their chances of relapse. And what you see in the specificity column is that if you detect circulating tumor DNA that matches the mutation profile of the tumor, then your chances of subsequently relapsing are very high. So again, this is a high positive predictive value. In most of the studies, the sensitivity, however, is reduced. There are a couple of outlier studies here, but overall, if you don't detect circulating tumor DNA, then you still have a significant fraction of people who go on to develop progressive cancer. So this is an emerging area, and I think what is clear is that a positive value, a positive test in the context of a patient who's had surgically resected disease, a positive test is a strong indicator that adjuvant chemotherapy is required. But whether a negative test is enough alone to adopt a watch and wait approach is currently unclear, and studies are ongoing to answer this question. So in the last couple of slides, I'm going to talk about two emerging targets that are generating some interest in the field. The first is inhibition of PI3 kinase. And this is data from a recent study looking at a specific PIK3CA inhibitor in patients with breast cancer, and showing a very nice difference in progression-free survival in these cohorts. So the PI3 kinase family have been interesting targets for quite a long time, but this is really the first demonstration of clear clinical efficacy, and likely relates to the difficulties previously in designing molecules that were effective enough in solid tumors. I should say in solid tumors, there are approval for PI3 kinase inhibitors in hematological malignancies. But here we have the first really good data in solid tumors. And this is of interest because alterations, genetic alterations in this pathway are reasonably common outside of breast cancer. And here I'm showing the distribution of PIK3CA mutations alongside inactivating mutations of PTEN, which also leads to activation of this pathway and could be a potential indicator of response to PI3 PIK3CA inhibitors that are not specific for the mutant version, i.e. that they can inhibit the wild type PIK3CA protein and therefore may show efficacy in the presence of PTEN abnormalities. So this is an interesting area. This agent will move into registration phase clinical trials in breast cancer and will quite likely trigger starting up of trials in other cancer types where the prevalence of PIK3CA mutations is high. So this is one to watch. Another area to watch is targeting of tumours with homologous recombination deficiency. So this is typified by patients who have mutations, usually in the germline of BRCA1 and BRCA2. And this is associated with a synthetic lethal response to PARP inhibitors. And we have approval of PARP inhibitors for patients with BRCA deficient mutations in breast cancer and in ovarian cancer. And of interest in ovarian cancer, there was an approval last year for maintenance therapy. And this is a relatively new concept in solid tumours. It's been around in hematological malignancies for a while, but the idea of trying to give therapy to patients in remission to maintain that remission is a new and interesting concept, for which PARP inhibition in BRCA deficient ovarian cancer showed good utility. So there are two areas where this pathway is of current interest: expanding the tumour types that are applicable and also expanding the molecular profiles. So this graph shows a breakdown by tumour type of the prevalence of mutations in BRCA1 and BRCA2, where we have current approvals, but also layering on disrupting mutations in other parts of the pathway, where there are preclinical and in some cases early clinical data that PARP inhibition may show efficacy. So shown here the genes ATM, PALB2 and CHEK2. And you can see that if there is indeed efficacy of PARP inhibition indicated by abnormalities of these genes, it really opens up a number of other tumour types at reasonably high prevalence as potential targets for PARP inhibition. Interesting data recently has come in the realm of prostate cancer, where it has been recognised for a while that patients with germline BRCA mutations are predisposed to prostate cancer. What has become clear now is that this is also a marker of highly aggressive disease, and this is leading to potential changes in guidelines and management of early non-metastatic prostate cancer, in that the presence of a BRCA mutation is a strong predictor of the development of progressive disease and may well be an indicator that these patients are not suitable for a watch and wait approach. So targeted therapy with PARP inhibitors is coming through clinical trials in prostate cancer, and there are also trials in prostate cancer that are looking beyond BRCA at additional markers such as ATM, PALB2 and other parts of the homologous recombination pathway. So in summary, I hope I've given you some insights today into how we can continue to improve the efficiency of the therapeutics that we have available through the use of genomic biomarkers, and offered you a little bit of horizon scanning of events that are just around the corner that we will hopefully be seeing in the clinic in the immediate future. So thank you for your attention.
Thank you, Dr. Beer. Very interesting talk. Just before moving to the talk of Dr. Boon, we want to raise an intermediate question about the circulating DNA. If you have if you can answer the following question, it will be interesting also for Dr. Beer to draw some conclusions. Okay, thank you. So now I will give the words to Dr. Boon, who will host the second part of this webinar.
Hello, can you hear?
Yes.
Hi. Good morning. This is Cheng Boon speaking. Thank you for having me. And
could you share your screen, please?
Share a screen, yeah. Okay. Sorry.
Thank you.
Thank you. Right. Good morning. Thank you for the talk by Dr. Beer. My name is Cheng Boon. I am a oncologist who have recently moved from a different center in the UK. My background is I am more of a clinical oncologist, so I do more radiotherapy than chemotherapy. But my involvement has been because I've been involved with the commercial sector as well, and I occasionally get patients referred who have run out of chemotherapy options. So these are chemo-refractory patients who's asking for advanced radiotherapy techniques such as proton radiotherapy. But in actual fact, those may not be the ideal group to use advanced radiotherapy treatments. So I have been looking at different technologies to see if there's anything else out there. And it so happened that OncoDNA was one of the companies that offered a potential different option. I can't say it offers treatment, but it at least offers a test for my patients. So my simple talk is about using advanced technologies in daily clinical practice. It doesn't matter whether it is clinical oncologist or medical oncologist. So the first question is, technology in oncology sector is always
Sorry, we lost the sound.
changing.
Dr. Boon, we lost the sound.
Is it ever possible as an oncologist to know everything about it? Be combining all this technology to not just stage the patient, but to treat the patients accurately, so that what I see in the genetic testing world has already been happening throughout oncology for decades. So we originally started with physical examination, X-rays, but we have now moved to things that you don't need to examine the patient. The test will be done for you, and it gives much better predictions. And for the past 10 to 20 years, oncologists have been talking about targeted therapies. Is it feasible to select certain patients to give certain chemotherapy and to select other patients not to give chemotherapy? The thinking process behind that is we're treating infections and we culture the pathogens, we test the different antibiotics, and somehow some treatment will work better than others. And some cancer cells are inherently resistant to certain chemotherapy options. Obviously, there are big limitations to this approach, as the pathogens in infection and pathogens in cancer are completely different. Now, cancer cells are very similar to human cells, and so the what they call a therapeutic index for the treatment is very narrow. The other thing with cancer is, obviously Philip has alluded to, is that there is a big tumor heterogeneity, and the way we sample the tumors are very limited. For example, in my background, I treat head and neck cancers, esophageal cancers, stomach cancers, and those tumor sites are fairly difficult to rebiopsy, and the tumor volume is quite substantial. So unless the patient has surgery to remove all of the tumor, we are unlikely to get a full sampling of the tumor. And finally, the third factor that affects whether the genetic testing approach is feasible is that once we give treatment, whether it is surgery, radiotherapy, chemotherapy, or combination, there will be selection pressure. And these treatments will change the genetic environment of the metastatic disease process. If we give platinum-based chemotherapy, with time, the platinum-resistant cells would it's just like infection would overwhelm the non-platinum resistant cancer cells, and that's just a matter of time. So one of the ways to understand this is this New England Journal paper was published in 2012, and this group of scientists did multiple biopsies and multiple genetic sequencing of the primary, of the metastatic disease process, and they found that actually what we think is the same cancer is not the same cancer. We knew that, more than 10 years ago, when you give chemotherapy, some lesions would respond and some wouldn't. But this is the first paper published in the New England Journal of Medicine that actually shows that there are some mutations that are common to all the cancers, and there are some who are driving the disease process. And those driver mutations are the ones that we need to treat, rather than to treat all the mutational. As Philip has said, tumor mutational burden just means that this is a cancer that has a very high mutational rate. There may be newer agents, not chemotherapy, that this is a signal of treating. Immunotherapy seems to respond to patients with high tumor mutational burden seem to respond better to immunotherapy. So the main problem in clinical practice is that we are never going to biopsy every single metastatic disease process. And one of the solutions may well be we do ctDNA disease sampling. And then we know that with changing of treatment, that this directs the mutational process as well. If you give cytotoxic chemotherapy, this may induce certain refractory chemorefractory mutations to predominate and render the cancer to be more invasive. But we do not have the capacity to actually monitor the mutational disease process as we treat. At the moment, what we do is we do chemotherapy. We give several cycles of chemotherapy. After a certain amount of time, we do a CT scan. Perhaps in future, we would do something like a few cycles of chemotherapy, a CT scan, PET scan, or even a mutational analysis, ctDNA. So what are the barriers that stops this from being adopted? So we have the concept of early adopters, oncologists, a small group of oncologists who would, perhaps in an academic setting, use this and validate the process versus waiting and seeing, because this DNA analysis process, it's very hard to do a phase 3 trial, because the way we do phase 3 trial is we limit the disease process to staging, to a certain mutational basis. We try and do the clinical trials with chemotherapy. We're never going to randomize patients to have ctDNA versus they're not, because we may not have the treatment if we find a mutation. So Philip has said we have found a Ntrack mutation, which may have an agent that could correct or treat that mutation. But the problem with that approach is that it is difficult to validate that in all cancer types, or perhaps you may have to do a study that has to be designed to look for the mutation rather than to treat all cancer sites. But that is something that is going to take a certain number of years. To get from phase 1 trial to phase 3 may take 5 to 10 years. The second big problem with genetic analysis is, as usual, extra cost. Now, cost initially will be expensive because this is a brand new technology. People need to see the benefit. At the present moment, they see the cost. Ultimately, whether there's benefit or not depends on finding the mutation, finding the right patient with the mutation, finding the suitable and fit patient who can tolerate the potential treatment, and also the payment for the additional treatments. Now, it is a bit of a chicken and egg approach, as paying for the upfront tests without knowing for certain that you will have something at the end of it makes it very difficult for oncologists to accept the test. So that is a very big hurdle to surpass, and it may be that the test and the drug has to go together. But that is something that will come as we have more drugs. The third issue is access. Access in the sense that where do we get this test done? How do we get the tissue or the blood test from the real life clinic all the way down to the patient, all the way down to the lab? So access could mean how do we get a biopsy or how do we get the ctDNA, and we don't have a unified way of collecting all these tests for the patients. It's not like you can send a patient to a CT scanner and at the same time take a blood test. That would be ideal if you want to do a network of treatment and scanning and DNA analysis centers, and that might be something in the future, but that would mean investment in terms of having nursing time, having the logistical approach available. But it's again chicken and an egg. Do you invest without knowing this will be used, or do you build the test first and then build a network? And I don't have an answer for that. And again, lack of access to targeted treatments already alluded to earlier, where the test uses the DNA analysis and the drug should come together. But there's no easy solution for that because we are discovering new mutation, and as the drugs are invented, they are all very untested because they are considered experimental agents. So you have to persuade your FDA and the NICE and the European licensing authorities to allow you to use these drugs. And finally, the biggest but unspoken issue is that the acceptance from the payment bodies such as the UK NICE organization as well as insurers will want evidence of benefit from these treatments, and it is very hard to show evidence of something that's still being invented. You are still discovering new mutations. As you have more patients have this analysis, as they have treatment, you will find more mutations that may make a difference. But at the present moment, to demand randomized evidence levels to prove that this is beneficial, or to meet the quality points approached by NICE organizations, is you are still some years away from that, I suspect. But I think we are there. We are adopting the early adopter approach, and I hope to see some further improvement in the next few years. So the cost implications: if this test is available for self-pay, the cost can be an issue, and the cost of the test, each test is done, let's say if you do it every 3 or 4 months, just like a CT scan after every few cycles of chemotherapy, can be a barrier. But obviously, if you can show that this is beneficial, there may be a group of patients who can afford to self-pay for this, provided the cost can be capped. So one option is to have a system that can allow the costs to be capped from being astronomical. Let's say the patient lives 10 years, will they be paying for a test every 3 months? But that is something that can be resolved with better testing, and as the price of the kit comes down and as more patients do this, the cost of all tests will come down. Just like a CT scan used to be very expensive, but as time passes and the system becomes more well used, the cost, I suspect, per test will come down. Now, if it is available on tariff or on insurance list, we will have to show that this is cost neutral for the insurers, because they are not going to pay extra money for a test without any benefit from the overall cost point of view. One of the potential implications that has been left unspoken is that this test could also end up saving money by avoiding expensive treatment that may or may not work. If you can find a mutation against standard treatment and you predict that these patients will not have any benefit, that actually saves the patient the complications risk, as well as the payment organizations the cost of those drugs. So we know that NICE is willing to pay money for this kind of genetic testing because they've approved and licensed Oncotype DX, which is to predict for chemotherapy decisions, and it is found to be cost neutral. We avoid treating the patients that have low risk. We treat the patients that have higher risk. It makes sense to the patient, it makes sense to the clinician, and it will make sense to the insurers and the payment organizations. So treatment pathways, from testing to accessing treatment, it has to be smooth, because the patients at the moment that are using this test are not the upfront patients. We are not testing for adjuvant treatment. I suspect the patients that will have this test, if they are self-paying, will be stage 4 patients who have already progressed on chemotherapy. Those patients will need a decision, or or at least the results of the test, on a fairly short notice. And we are talking about within 2 to 3 weeks, we need to have a decision, or the patient will will deteriorate clinically and may not be suitable for further testing or further treatments, of which then your potential pool of patients will not be very big. So from my personal experience, at the present moment, the DNA analysis is being done on a select case-to-case basis. Most of the patients with head and neck and esophageal squamous cell carcinoma are platinum sensitive. Nevertheless, there is a small group, probably less than 5 to 10%, that will be refractory to platinum-based chemotherapy, even at a presentation, what we call de novo refractory disease. The problem with that is I do not know who will be refractory. We treat everybody the same with chemotherapy and radiotherapy concurrently, but I suspect in the future, if we do the DNA analysis before we do the treatment, it may predict that 90% of the treatment is correct, but the 5 to 10%, the long tail, may need better or different treatment. Now, at the present moment, I cannot justify paying for these drugs and this test without evidence. And to do that evidence, if we are going to ask for a phase 3 trial, it will take another 5 to 10 years and cost millions of pounds. One of the ways to do this is to go back retrospectively with our academic colleagues and see if they can test this on previously treated patients, the ones that have been refractory to standard treatment. And I suspect that is how DNA analysis tests will be initially used, rather than to use it on all cancer patients. The experience in the UK is there's about 300,000 new cancer patients a year of new diagnosis of cancer, and to justify the cost of additional cost of doing this test on every patient may not be possible. But the world is changing. The Prime Minister Theresa May has said she would like to have all the children or pediatric cancers tested for DNA analysis in future. Now, it may be that children's cancer are 1% of the population. That is to 3,000 patients a year. I am uncertain if the UK, NHS or private, has the capacity to test this DNA analysis of all cancers. And I suspect the investment and the facilities and the capacity to do the test will not be available if a political or insurer's decision were to say, I want to test all DNA for all cancer patients. So again, I suspect the pool of people here listening to Philip and myself talking today is small, but we are ahead of the curve, and I suspect that the decision in future will change. The problem is it will not be a slow change, it will be a sudden switch, and is usually because the evidence has reached a tipping point, and suddenly everybody wants a test. And that's why we should prepare ourselves as oncologists to be accepting of new technology. Now, there are limitations to all technology, and we cannot use the DNA analysis just on all patients. And I suspect even with the test, we still have to use clinical judgment, as again, there are limitations to all DNA testing, just like there are limitations to all imaging modalities. So we've talked about refractory disease and the fact that this is probably the group that will use this test initially. And that is my talk today. Thank you.
Thank you, Dr. Boon. Now we have time for your question. So if you have any question to raise to the audience, so please use the question panel on the right of your screen. So we have already some question for Dr. Boon. You talked about it's So yes, you talked about the pathway implementation that are the main barrier to get oncoDNA tests that are already reimbursed by many private insurers implemented in hospital pathway. And what would be the solution to make that happen faster? I mean,
so from my experience dealing with the insurers, they want to see that your test is valid. They want to know if this is going to lead to need a treatment. So they don't want to test just for the sake of testing. So from personal experience, one of the patients I had was a patient who had refractory disease to chemotherapy. The patient had progressed on 2 lines of chemotherapy. So there's no standard treatment for these patients. And I had to say that if we have no chemotherapy option, one of the tests we look for is immunotherapy. And the patient had a fairly rare cancer, a small bowel metastatic adenocarcinoma, which is less than 1% of all cancers. And as such, these are considered orphan cancers. There are no mutational analysis, there are no immunotherapy trials being run. So I wrote to the insurers, I said, if we find a MSI or a high mutational burden, there is a drug called pembrolizumab. At the end of it, if they test positive, we potentially could justify using this drug. But the test by itself alone is not enough. So I suspect the insurers will want a two-way approach. You have a test and you have a treatment question. Can this patient have this treatment? Yes or no? So that is one approach. The other approach, if you want to use it for all treatment patients, is that you save treatment. So let's say you do the analysis initially on all patients, and you say this drug is not going to work, so we save the patient from having this drug, then yes, you can justify it. At the present moment, to use this test without having a justification is going to be unlikely to get through the insurance, would be my opinion.
okay, clear. Thank you, Dr. Boon. Does somebody has still other question to raise to the speakers? So I have another question for you, for both presenter from Dr. Janice and Kans. Early access to new drugs via compassionate use. The question is, what about the early access to new drugs via compassionate use?
Sorry?
But perhaps
Yes.
I can speak to that first of all and then pass over to Dr. Boon to get an opinion. It is an interesting area. It is an area where one feels that we should have access to these drugs. What I would say is that it raises important ethical questions about whether treating people without collecting outcome data is acceptable. So in an ideal world, we would have a mechanism to offer therapies where there isn't actually an approval, but to collect and collate outcome data so that we can see, as this happens repeatedly, whether there is actually efficacy. Because I would argue that it's not necessarily ethical to give an experimental drug and not to aggregate the outcome data. But I will hand over to Dr. Boon now for his opinion on that.
Sorry, the issue about using unlicensed drugs based on the mutational analysis would be, as Philip say, unethical, and you are unlikely to get through FDA or any of the approving process, because the drugs will come with their own side effects. And in the population that we are treating, the metastatic disease process, again, we worry about not just the accuracy of the test, but tumoral heterogeneity, which could mean that it may work for some of the cells, but it doesn't work for the rest of the cells. And that's where we do need to collect the data. And it may be that we approach the drug companies and do a study, but this is not unreasonable, because we know that the pembrolizumab did have a study on TMB patients, and they selected all TMB patients regardless of all tumor sites and actually funded the studies. So if you have a new drug and they are looking for licensing indications, there may be capacity to join this up, having a test and having the drug and having a trial, because again, the insurers and the NICE will not pay for a drug that is predicted to work but has not had a phase 3 studies. Now, it would be difficult if you are talking about a rare cancer, like cancers that are less than 1%. But on the other hand, there are ways around it. To do an academic study would mean having the test to predict and then selecting all the mutational positive patients into the studies. And they may be uptake for this. It's just getting all this together as a organization and having the capacity to run the studies in a sensible manner.
Thank you, Dr. Boon. I have another question for you from the audience. Based on what Dr. Beer presented, do you believe that ctDNA analysis could potentially replace solid biopsy testing? And if not, why?
So Dr. Beer's slides have explained the ctDNA issue. And again, if you look at the slides that he gave you, the heterogeneity is greater in the tumor sites that are difficult to biopsy. So if you look at his slides on gastric cancer, you'll notice that the tumor itself, the primary tumor, has a very high tumoral genetic heterogeneity. And one of the suspicions, I can't prove this, is that these tumors are very difficult to biopsy. And so you're not getting a full sampling of the tumor itself. And if the primary is not removed, there are many more mutations that will generate different mutations as you treat. Now, one of the issue is about the ctDNA is you are only testing for the ctDNA that can travel in your bloodstream. Now, obviously, that's already a selection bias. The metastases are more likely to metastasize if you understand what I'm trying to say. So the primary tumor may or may not lead to death. That comes back to the clinical experience of the clinician. If you're treating a primary stomach cancer that has low volume metastatic disease, it is usually the primary that will lead to the end of the patient. And ultimately, that's what the patient wants to know. Can you prolong their life? Now, if you treat all the metastases and leave the primary alone, the primary will still bleed and lead to the end of life. So having the ctDNA or the primary tumor biopsy or all this DNA is still limited by the fact that you do have to have clinicians who have a bit of experience treating the cancers you're talking about. Yes, we can do all the treatment based on genetic analysis, but there is something to be gained by knowing the clinical disease process. And that is one of the difficulties of being an oncologist. We are increasingly asked to know everything about every cancer rather than being focused on one or two tumor sites that we are very experienced in treating. So I suspect there is a use for the ctDNA for the tumor sites that are difficult to biopsy because of accessibility or patient being unwell or the risk of bleeding. And that probably is the best you're going to have unless you're willing to subject the patient to an invasive biopsy. So it is an incomplete test, would be my sincere opinion.
Okay, thank you. Philippe, do you have element to comment?
No, I agree. I think what we will find, I don't think it will ever replace tumor biopsy. What we may find going forward is that there are very specific circumstances where there is utility. And I mentioned in my talk a more recent study looking at platinum-treated patients with BRCA mutations. And there you have a very clear differentiator that's been shown to be clinically useful in terms of where you go with your next therapy. And I do think the area of minimal residual disease monitoring will be of interest. The basic problem with how much blood you can take and whether you have DNA in your tube is one that may be difficult to resolve. We can't be taking half a litre of blood in order to test it. But there may be other devices that become relevant to that. So is it possible, for example, to have an implantable device that takes circulating DNA out of the circulation over a period of time that can then be analyzed? So there are potentially, it sounds a bit science fiction, but there are people looking at this kind of biomedical device approach to collecting ctDNA. So, and that may then open up further avenues, particularly in the realm of minimal residual disease detection.
Okay, thank you. I have a question also for Pakistan. What about the indication, the clear indication for liquid biopsy in developing countries like Pakistan?
I wonder whether the context is to do with access to biopsy as well. I guess we accept the fact that in Western medicine that we can generally get biopsies, and the only thing that is likely to stop is if the patient is not sufficiently fit for biopsy. So if that is different, then it might change the equation, because ultimately getting some information is better than getting no information at all. So if there are differences in availability into invasive procedures and radiographical biopsies, etc., or surgical, then that could potentially change the equation. So at the end of the day, if there are targeted therapies that are available, then accepting a test with a reduced sensitivity would be better than having no test at all.
Thank you. Thank you. Thank you, both of you. One last question to the audience. Is there any other question you want to raise? It's the last minute. No, thank you. So then in this case, dear doctors, I want to thank you for your presentations that were very interesting and brilliant. So I wish you all a very good rest of the day. You will receive soon a mail to access to the video of this webinar and an invitation to comment the quality of this program. We want to apologize also for some background noise you may have here during this webinar that will be solved for the next one. Anyway, we will appreciate your feedback, and we wish you all a very good day and hope to see or hear you soon back for the next webinar. Thank you very much. Bye-bye.
Thank you. Bye-bye.